consultant cardiologist. Today, we have a very interesting topic, and I invited my colleague, Dr. David Khoo. So who is Dr. David Khoo? He is the founder and medical director of iHeal Medical Center in Kuala Lumpur, and he began his medical career in 1989 at University Hospital Kuala Lumpur. And within 4 years, he qualified as a surgeon, having obtained the fellowship of the Royal College of Surgeons of Edinburgh. He subsequently has subspecialty training in cardiothoracic surgery in Institute Jantung Negara and underwent a fellowship in advanced cardiovascular and thoracic surgery at the Mayo Clinic in 1996. He was appointed as a consultant cardiothoracic surgeon at IJN in 1999. He started his private practice in Ipoh Specialist Hospital in 2000 and since then practiced at Subang Jaya Medical Center, Grand Eagle Intan Medical Center, Prince Court Medical Center, before finally setting up iHeal Medical Center. He is the champion of our Sweat Solution Center in iHeal, and he will tell you how many cases that he has done. And today we talk about this condition called sweaty palm. And palmar hyperhidrosis affects about 3% of the population, and it inflicts significant impact on quality of life. It's characterized by chronic excessive sweating, not related to heat loss. So with that introduction, the floor is yours, Dr. David Khoo. You can go ahead. Thank you.
Thank you, Dr. Wong, and also for the fellow doctors who are tuning in today. Well, I'm sharing a very interesting condition that is common yet uncommon. Common because I see them, yeah, but uncommon because in the normal incidence, it's not high in percentage, but it is a very debilitating disorder. And over the years, I've treated it since 2001. So it's been 21 years since I started treatment for this condition. I've seen over 2,000 patients, and I find that this condition really is a problem for them. And certainly today, I hope to share some insights and give some information about this condition known as palmar hyperhidrosis. Next slide, Jen. And this is a situation where the sweating is excessive. Therefore, we call it hyperhidrosis. And the common areas that we see this will be in the palms. And those patients who get excessive sweating in the palms, they often have excessive sweating in the feet as well. But we do have patients who have it in the armpits as well as in the face. In fact, if we look at the etiology of this condition, we don't really know for sure what causes this, but we know it's related to overactivity of the sympathetic nervous system. And there tend to be some genetic basis for that because we see that in families. Next slide. Now we look at excessive sweating. You know, when we know that in our medical training, excessive sweating can be seen in conditions like thyrotoxicosis, even when the person reaches menopause, in obesity, in psychiatric disorders, and even systemic malignant diseases like lymphoma. But in hyperhidrosis, it's different because the sweating in this situation is localized in certain areas, as in the palms, in the soles of the feet, as well as perhaps in the armpits or even in the face. Next one. Now, this is a condition, previous slide, please. This is a condition when there is axillary hyperhidrosis. You can see a person presenting with excessive sweating in the armpits. And this is where they can't wear clothes of this color. And certainly they come with it a certain body odor as well. Next slide. The characteristics of this condition is typically centered on number 4, where this is provoked by emotional stress and is made worse during hot weather. Having said that, even when the weather is cold, I have patients who are, when in times of winter or when the air conditioner is at full blast, they are cold. But because they are nervous, they start to sweat in the palms as well. It is certainly not provoked by exercise, and it stops perhaps only during sleep. Although for many, even at times like that, they still continue to sweat. Thanks. This condition really doesn't affect, in a way, health per se, but it does cause psychological, social, and professional disabilities. I've, over the years, treated patients from different vocations. We have doctors who struggle to do physical examination of the patient or who have problem putting on gloves. We have accounting students, accountants, lawyers who deal with managing a lot of paperwork and often causing these papers to be wet. We even have technicians, electricians who worry about getting electrocuted, and even those in the F&B industry, because you need a dry pair of palms for you to be able to do your work. Next slide. If we look at the treatment options, now over the years, like I mentioned earlier, prior to 2001, when I introduced this surgery in Malaysia, many GPs who treated this condition thought this is related to perhaps even anxiety disorder, perhaps even cardiovascular disease. So patients have been put on beta blockers before, on anxiolytics. But in reality, it is a vicious cycle where excessive sweating leads to anxiety. Anxiety causes more sweating, and we need to break that cycle. And one way to break the cycle is to use antimuscarinic medications like oxybutynin. Unfortunately, it's non-specific, gives side effects of dryness in the mouth, constipation, and even hypertension. And besides, you can't use it for too long. There are antiperspirants like Perspirax, dry claw, that you can apply onto the palms, and that causes the aluminium hydroxide that's in this antiperspirant will block up the sweat glands and perhaps hoping to reduce the sweating. It, however, is linked to inconsistent results. Antiperspirant is a technique where you soak your hands in water and then run a direct current to electrocute the glands. It is often time consuming. You need to repeat many times in a week, and often after a while, it doesn't lead to much change. Botox does work for some. Only thing is you need to give 50 injections in each palm and need to be repeated every 6 months. And often patients after an episode tend to stop. Now, the best treatment in my mind after having tried all this is surgical treatment, where the problem is an overactivity of the sympathetic chain. We then identify the area that innervates the part that we try to reduce the sweating, and we will then apply 2 clips onto the sympathetic chain. And we know from our anatomy that this sympathetic chain lies along the vertebral column, right from the cervical thorax span, all the way down to the sacral region. And if we are trying to address sweating in the palms, then we tend to disrupt the nerve at the 3rd thoracic level. If it's the face we are trying to address, we look at the 2nd level, and if it's axillary, we look at the 4th level. Stellate ganglion will be, and if you interrupt that and cause injury to the stellate ganglion, you will get ptosis and hydrosis as well as mydrosis. So this is what you see, a Horner syndrome. So we should avoid that when we do the surgery. Thanks. Next. This surgery is new per se, is building on tumors in the sympathetic chain, and when it was removed, the patient often report reduced sweating on one side of the body. But at those days, of course, when we were trying to address it using surgery, we need to do a small thoracotomy. That itself is not attractive. It causes pain. There's considerable risk. But now, in the advent of endoscopy, next slide. Next slide, please. Now, in the event of endoscopy, with the use of small cameras and video system, it makes the operation safer with very minimal scarring. We now make only 2 5mm holes or incisions in the armpit, one for the insertion of the camera system, and the other for the clip applicator. With these 2 incisions, we will be able to see the whole vision in the hemithorax, and then identify the nerve and apply the 2 clips. I normally only take approximately 15 minutes to do both sides. Thanks. Next slide. And following the surgery, you will see 2 small little 5mm scars in the armpits, and each of these scars, after a time, will not be visible. Now, this condition gives rise to immediate response. The hands will turn warm immediately because the moment you denervate the sweat glands via that sympathetic chain, we will then see a dry pair of hands as well as a warm pair of hands. Next slide. And the effect is often permanent with a very small recurrence possibility of 1 to 2% because of the presence of an accessory nerve or cones. And often when I started this surgery 21 years ago, I was dividing the nerve using chloride. But since 2006, I found that there's really no need for us to disrupt or damage the nerve, but simply by applying 2 titanium clips onto that level of concern, we should be able to denervate the sweat glands. It caused an almost 100% success to the sweating in the palms, approximately 80% in the armpits. And for those who have sweating in the feet, the nerve being at the sacrolumbar region, I often feel that it's not the right place for us to be operating on because it may affect the libido of the person. But in those cases that has sweating palms and feet as well, in about 60% of them, they also noted an improvement in the sweating of the feet. Thanks. As in any operation, there's often thought about side effects. The side effects are rare. I mean, if you do it correctly, I mean, you should avoid injury to the lung, injury to the heart, but there is a possibility of severe compensatory sweating. Because when you stop the sweating in that palm area, often these patients do not sweat at the back and elsewhere when the person is warm or hot. But when that is disrupted, often there's compensatory sweating at the back, sometimes in the thigh region as well as the lower abdomen. It is at most times tolerable for most patients, although in some, especially when I was dividing nerve years ago, there was an excessive compensatory sweating, and for that, there is also a concern. There's a little risk of possibility of creating a small pneumothorax because when we insert the trocar, if the lung doesn't move out of the way, there's a possibility of us scraping that lung, leading to a pneumothorax. But this is often treated conservatively by introduction of a small tube for 24 to 48 hours. And often in this surgery, we will use carbon dioxide insufflation so they can move the lung out of the way and that we can come and bring the sympathetic chain onto view. Next. In conclusion, this is a safe operation, a short surgery, and if done properly, it gives very good results with very minimal scarring. And I see that it actually has the potential to really remove one problem and not be replaced by another if we do not divide the nerve. And for those patients where we got the surgery, often following the surgery, I see a renewed level of confidence, and I find that they certainly are a lot happier than before the operation. Next. Let's look at the video of how the surgery is done.
Is there any other complementary treatment that can be used, like stress reduction, meditation, or any herbs that can help?
Often the patients will ask me, they say, "Doctor, is my condition severe enough for treatment?" So I often tell them the severity depends on your ability to manage with these sweaty palms. If it doesn't affect you, meaning you can live with this condition, then in reality, you probably don't need any form of treatment. But if this is affecting them in the activities of daily living, then I would like to know, is it a source of stress? And if you think you can manage your stress, you can manage, like you say, perhaps meditation or any other means, and that gives you that form of confidence, then perhaps that sweating itself will be reduced. Because as you see in some patients who are older, they bring their children with this condition. They say that, well, when I was younger, I was affected by it, but today I'm okay, I'm no longer affected by it. In that situation, then of course, it means that there's probably no need for that person to have surgery yet. But often, like I say, it's a vicious cycle. The moment it starts sweating, it gives rise to anxiety, and the anxiety causes excessive sweating. Excessive sweating causes more anxiety, and often we need to disrupt this vicious cycle. The video is on now. Let's go back and show that video. Any playback from beginning? As you can see from this video, on the 12 o'clock level, you see the heart that's pumping away. And on the 3 o'clock level, you see the lung. And you can see that white sympathetic chain. So in the technique where I used to cauterize the sympathetic chain, I just use a cautery to divide it into two. But in this context, because we are trying to clip the nerve, we isolate the nerve first, and then bring in the clip applicator to apply two Liga clips, which is made of titanium, onto this level that we wanted to. To reiterate, if I'm looking at correcting excessive sweating in the face, I'll be targeting at the second thoracic level. If I'm targeting the palms, it'll be the third thoracic level. If I'm targeting the armpits, it'll be the fourth thoracic level. So thank you for that video. Okay, Dr. Wong. So this is what the video shows. Yeah.
There are a few questions for you. One is whether this operation is covered by insurance and how much does it cost to be done at IU Medical Center?
Okay, well, first of all, as in anything else, whether it's covered by insurance, there are two considerations. The first consideration is whether it is included as an exclusion criteria in the policy. I think some insurance companies over the years, I remember when I started this surgery 21 years ago, there were no such exclusion criteria. But lately, I find in some policies, there has been exclusion criteria for hyperhidrosis. Well, frankly, to be fair, many of these are pre-existing conditions, meaning the person may not have it at birth, but they have it when they are young. And by the time they buy the insurance at maybe as a teenager or as a young adult, they will probably be having this condition for the past few years. So that itself become an exclusion because it's a pre-existing illness. But if it's not mentioned and it's only been noted early or recently to affect the activities of daily living, then it can be used as a reason for the person to claim an insurance for this condition. This surgery right now in IHEAL costs approximately 9,988 ringgit all in. Yeah, although it ranges, yeah. This operation ranges from one place that could be what we are now, or even as high as 15,000 elsewhere. So it really depends on the place where they go for. But in IHEAL, we do it as a daycare procedure. I only take 15 minutes. Normally leave the center about 3 or 4 hours after the surgery.
Okay, there's a question from the audience from Dr. Kamalak. So the question is written this way. If they go for this treatment of sympathectomy, is there any chance that they have a long-term cure? Means they have a long-term dryness of their hands.
As I mentioned earlier during my presentation, when I first started this operation, I was doing it by cauterizing and dividing the nerve. I found that when we do that, yeah, it causes quite severe dryness in the palms. And in addition to excessive sweating as a form of compensatory sweating at the back. And that is not a favored situation because you are replacing one problem with another. So this is when around the year 2006, that's when I converted this procedure into sympathicotomy, where we do not divide the nerve, but we only clip onto the nerve. I find that when we do that, the sweating in the palms is certainly at an acceptable level. I think all we need to do is reduce by 80-90% of that kind of sweating they had before. And that itself will not lead to excessive dryness of the palms. But more importantly, at the same time, it doesn't give rise to excessive sweating that is unbearable at the back or lower thigh or lower abdomen. So I find that this technique of sympathicotomy, where we clip the nerve instead of cutting the nerve, gives a better outcome. So the answer is no. I think there should be no long-term excessive dryness of the palms if we use this technique to treat this condition.
Okay. The next question is this surgery reversible? In some patients who may have excessive dryness or excessive sweating in other parts of their body, like the back or the buttocks, so is it possible to reverse the surgery?
Now, this is the other benefit of clamping the nerve instead of dividing the nerve, yeah? Because theoretically, we can go back in and remove the clips. Because when you remove the clip, we are restoring the continuity of the nerve. But having said that, remembering that we apply quite a heavy pressure onto the nerve, and there will be some form of neuropraxia. Although it's not neurotmesis, but there's a lot of neuropraxia. So therefore, for it to be able to regenerate and establish continuity, it may take time. Over this period of 21 years, there have been a few patients that I do remove the clip. I think not more than 10 of them. But these are often because the compensatory sweating might be severe, or they feel that now they have changed job and they're out in the heat, in the sun, and they find that the CS is something that is not bearable for them. So these are the only situations that I do remove.
David, we cannot hear you. Maybe you have to turn off your camera.
And
we cannot hear what you said just now.
They come back to follow up. Improve. Okay, so I hear me now?
We can hear you. Can you repeat your last two sentences?
Okay, I was saying that, when we are using sympathicotomy, where we clip the nerve instead of dividing the nerve, it will give this possibility that we can reverse the condition. And there have been a few patients that I do remove the clip. I think just a handful who complains that the compensatory sweating was kind of severe, and they wanted to see whether by removing it, it will give to improvement. And to be fair, I think they have not come back after it's done. So I presume it has helped them a bit. But I often tell patients before we consider surgery, always remember that this is potentially not reversible. Because after having clamping the nerve for a certain duration, sometimes we are not able to be sure that this neuropathy, will be able to be restored. Because you apply a significant pressure onto the nerve at the time of clipping the nerves.
Okay, thank you. What is the worst complication that you had doing this operation?
But to be fair, I think we look at. I mean, this operation is relatively new in the country. New in the sense a few of us have done for a longer period, but some are new at it. So what I've heard has happened is, of course, you can inevitably injure any vessel. I'm sorry? Sorry?
Nothing. No, it's from Faisal. So you can continue.
So I'm just saying is that, there have been cases where, I mean, accidental operation, you can have bleeding, you can accidentally, injure the lung. But I think properly conducted so far, I've not had any mortality from it. And certainly no major bleeding. And there's one patient, however, who had some adhesions between the lung and the pleural space. And then on dividing that, there's a tiny bleeder that over time collected and led to a hemothorax that I needed to evacuate. But that came days after. That was the only one. Of course, there have been occasional cases where we grazed the lung when we inside the trocar, and we needed to put a chest tube for 24 hours or so until the air leak stopped on its own. But otherwise, there's been no major complication that leads to long-term disability.
Okay. There's another question from Dr. Kamala. The question sounds like this: clamping of the nerves, won't it cause neuropraxia, which might cause permanent damage of the nerves? So you explained it earlier. Maybe you explain again. Clamping on nerves causing long-term neuropraxia, permanent damage of the nerves.
Well, I think we look at the classification of injury to the nerve. Remember, we have externopmesis, neuropmesis, and neuropraxia. And of course, in this case, when we clip onto the nerve, we are applying pressure on that particular area. Then we are actually causing neuropraxia. But the main thing to remember is that this sympathetic chain is a plexus of nerves. It's not like one level is inhibited by only one particular, segment. So I think, even in cardiac surgery, sometimes we occasionally, for long QT syndrome, we do remove a certain segment of the thoracic sympathetic chain. Even then, that doesn't reduce the heart rate to a significant level until we require a pacemaker. So certainly this presence of this plexus of nerve in some ways protects the person from any major complications when we disrupt a certain area to bring effect of this reduced sweating to the palms. And the neuropraxia itself, upon removal of the clip, given time, perhaps a year or more, sometimes they can regenerate and then restore the continuity. And these are the only a few cases that we need to remove for a potential reversal that we hope will restore the person's perhaps sweating in the palms that they wanted again, or perhaps even reduce the compensatory sweating at the back.
Okay, so who else offer this operation, and is there any technical difference between your technique and other of your competitors in Malaysia?
Well, generally when I trained in the United States and I have a friend in Hong Kong, that's when I was exposed to this surgery back in 2001. But it is one world expert that I learned the most from. He was a Taiwanese surgeon that I visited in 2006, who then, because by then I've done a fair bit, but I wanted to know whether the technique that we are doing is the best. And this is when I learned the technique of clipping the nerve instead of dividing the nerve. So by and large, most thoracic surgeons, they would have or wanted to learn how to do this operation. And why is ideally a thoracic surgeon? Because we are entering into the thoracic cavity. In the event we cause an injury into the lung or perhaps an injury to the vessel, we can then proceed to a thoracotomy to do the repair. So ideally, it's done by thoracic surgeons or anybody who's capable of doing a thoracotomy. I think if we do the techniques, technically there are two. It's either you divide the nerve or you clip onto the nerve. Today, I almost 100% clip onto the nerve, except in the case of a recurrence. Then I will go in, if they wanted to restore that kind of dryness, I go in and divide the nerve. Otherwise, it's often just a clipping onto the nerve.
Okay, thank you. We are about 192 live audience at the moment, and I'm waiting for more questions to Dr. Khoo. So while waiting for the questions, maybe I ask you more about what you're doing. You are the director of iHeal Medical Center, and there are some other plans that you have in your mind. Maybe you can share with us for the next few minutes while waiting for the questions.
Yeah, I think I would like to share the motivation of why, as a doctor, I like to build a medical institution. I had a great fortune of being trained at the Mayo Clinic. Yeah, and as we all doctors know, Mayo Clinic is more than 100 years old. I remember that was way back in 1996 when I went to Mayo. When I first arrived, I asked myself, what's so great about this place? As much as I wanted to go to, when I get into that place, I asked myself that question. Because I remember at that time, Mayo Clinic was doing about 1,000 over heart surgeries. I was trained at IJN. We were doing about the same number. And at that very moment, I was just trying to figure out, I'm here for training. I still remember my boss at that time there told me this statement. He said, you're here to learn. We're not here to teach you. I mean, it was a very profound statement when he gave me that statement, because it, number one, tells me that this is a world expert. This is one guy who is revered in the cardiac surgical fraternity. And then he is telling me things like that. I mean, at that moment, I was wondering, why did he say things like that? I thought we are here to be trained. That is when I realized, and I also, as time goes by, realized as doctors, what we're going to be really depends on what we want to be. It's not about what people teach us to be. So at that moment, this is when it dawned on me, if we want to be great doctors or good doctors, we have to set that standard for ourselves to aspire to. So with that belief and that training, when I came back to Malaysia, I looked at the scenario around me. Of course, I came back to IGN first. Then I looked surrounding and I think there is a certain gap that I think we need to fill. I think most of us, when we started medical school, we go in with the greatest intentions. We hope to be one of those, giants, the professors that we look up to and hope that someday we'll be like them. But along the way, sometimes we lose our stamina. We lose our zest. And this is where I hope to group a group of doctors together. The way Mayo Clinic founders did. A group of doctors together who are passionate about the field of medicine, who want to be the best they can be, and then set an environment and ecosystem that will propel them forward, and then for them to train more people, and perhaps then we can even lift the standards of healthcare, not just in Malaysia, but for the region. So that was the ideals that I was holding to. Of course, it's easier said than done. But thankfully, and thanks to you too, Dr. Wong, you've been with me for the last 12 years as we started iHeal together. I think we've been able to stick to this core value, that we are just trying to bring the best of what we are exposed to. And of course, bring more of those we have not exposed to, but younger doctors who are exposed to come together and be that kind of a medical institution. So that was the motivation of why iHeal was started. And of course, having done that for 12 years, it's time for us to grow bigger. It's time for us to be able to attract those young people who have the most ideals in them still to come and join us and build this medical fraternity. And that also includes those that are listening to us, those general practitioners who, while they may not be practicing the specialty that we do, but we need them to be able to together support us, because we only do that portion. And after that, the patients returns to them. For them to be able to bring that greatness of what I think we get sick ourselves, and we hope not to need to go anywhere else for treatment. I mean, like those Americans, you never hear them going to another part of the world for treatment because they have it all there. So that is my great intention of hopefully we can do something of that nature. May not end up in our lifetime, but at least we got the ball rolling. And so this is the ideals that I'm trying to adhere to.
Thank you, Dr. Khoo. Is there any questions from the floor? Okay, there's no other questions. I also want to mention that Dr. Khoo is a cardiothoracic surgeon, and his technique is a bit different from others. He do off-pump cardiothoracic bypass, and maybe when we have a chance, we can invite him to talk on this platform again. So I think with that, I will stop here because there's no more questions from the floor. And I thank all of you for listening, and hopefully you can learn something useful. And if any of your patients are severely affected by this sweaty palm and also sweaty armpit, and there's a solution for them, and it's a very safe solution, and it's not too costly. I remember I met a patient who was so psychologically affected by this sweaty palm. You know, he's just a teenager, and he was so depressed and unwilling to meet up with other strangers. So at least you are aware that there's such a solution that's available for Malaysian. And there are a few other people who also provide this service, but you can find out more about them. David Khoo, Dr. David Khoo is one of the more experienced one that have been doing for a long time. So with that, I thank all of you for listening, and thank you, Dr. David, for teaching us about this surgery. Okay, thank you. Bye-bye.
Thank you, Dr. Wong. Thank you.
Bye-bye.